Welcome all to the today's session. So today's talk is on birth after previous Caesarian section. It is a Green Top Guideline number 45 published in October 2015. Okay, we begin with our quote, Master MRCOG with concept-oriented clarity. So we will clarify all our concepts from this particular guideline. Okay, so coming to the VBAC. So whenever such patient is there with a previous Caesarian section, what we have to do, we have an option of vaginal birth after Caesarean section or elective repeat Caesarean section. So there has to be some checklist, and that checklist we need to go through during the counseling. Okay, and then we will do the decision making and we will document it. Okay, so during antinatal care, always VBAC versus ERCS, that is elective repeat Caesarean section checklist is used, and counseling is done and decision making is performed and everything is documented. Okay, which are the patients who are suitable for VBAC? Remember here, this is the most important thing. So which patients are appropriate? Most women with singleton pregnancy with cephalic presentation, more than 37 weeks of gestation, and single prior lower segment Caesarean section. Okay, these are the most suitable patients for vaginal birth after Caesarean section. That is singleton pregnancy, cephalic presentation, more than 37 weeks of gestation, and single prior lower segment Caesarean section. When more than one or two Caesarean sections, there are certain things which are mentioned in the guideline that we will also cover later on. Okay. Now, which are the contraindications? Okay. So specific contraindications, remember, if there is a previous rupture and the placenta previa. Okay. So previous uterine rupture, classical Caesarean scar, and major placenta previa. Okay, so these are the three contraindications: previous uterine rupture, classical Caesarean section, and major placenta previa. Then, in cases of complicated scar, like you have previous inverted T or J-shaped incision, then there will be case-to-case review by the senior obstetricians. Okay, so the cases where there is a complicated uterine scar, they will be reviewed by the senior obstetrician, and then case-to-case review will be done. Otherwise, these are the three contraindications for VBAC. Then what about more than two or more than two previous Caesarean sections? VBAC can be offered after senior counseling, delivery only in centers with immediate surgical backup. Okay, so again, senior counseling is required in these particular cases. Then what are the risk factors for uterine rupture? Okay, so assess individually if additional risk factors are present. Until we have to counsel the patient, and always document the discussions and final decision before the delivery. Plan for labor before schedule elective ERCS date. Okay, so if the patient goes in labor, she may be offered this. There is chance that you have posted this patient for elective repeat Caesarean section, and she may go in labor. Then what should be the plan? That should also be discussed and documented. Okay, and always use VBAC checklist and provide patient information leaflet. Okay, so now what are the risks and benefits of both VBAC as well as repeat Caesarean section? So if the patient undergoes successful VBAC, so when the patient will undergo successful VBAC, it has got a lowest complications, while the highest complication will be there if the patient is posted for VBAC, but if the patient is posted for VBAC but undergoes Caesarean section. Okay, so have you understood? The Caesarean section during the VBAC will have the highest risk. Okay, so VBAC, what is the rupture rate? It is 0.5%, that is 1 in 200. So rupture rate is 0.5%. Can anyone tell me where in obstetrics we have come across 0.5% prevalence of various conditions, somewhere between 0.5 to 0.6%? Any other condition which we have discussed? Any idea? What is the prevalence of shoulder dystocia? What is the prevalence of cord prolapse? Okay, just check it, all those prevalences, and compare. Okay, that will be less than 1%, somewhere around 0.5, 0.6%. So VBAC risk of rupture is 0.5%, that is 1 in 200 Remember, this can be asked as a SBA. Now coming to the perinatal death risk. Perinatal death risk in VBAC is very low. It is similar to the first time delivery or primary first time mothers. Okay. Now coming to the elective repeat cesarean section. Now this patient who has got previous cesarean section, there will be increased risk of placenta previa, accreta in the future. Chances of adhesions and neonatal respiratory morbidity will be there, especially if you conduct the delivery before 39 weeks of gestation. And what is the likelihood of success of VBAC? Again, this is a SBA, numerical SBA. Success rate is 72 to 75%. Now here, please remember one thing. If you are asked about the success rate of the VBAC, don't answer this figure blindly. Okay, you have to remember this particular figure, but read the scenario carefully, because success rate differs with different scenarios. So read the scenario carefully and then answer. Okay, I'll discuss further in detail. Say for example, this line. So best predictor is the previous vaginal delivery. This can be asked as a question. SBA, what is the best predictor? If the patient has got previous one vaginal delivery followed by cesarean section, or cesarean section followed by one vaginal delivery, then the VBAC success rate is 85 to 90%. Okay, and it has got a lower rupture risk. So whenever VBAC success rate is asked, always go through the scenario what happened. This is in general. Okay, is given 72 to 75%, but if there is a previous vaginal delivery, your answer will be 85 to 90%. Now coming to the intrapartum management. So conduct VBAC equipped obstetric unit with continuous monitoring along with the immediate cesarean section facilities. Then unplanned labor after cesarean section. Okay, those cases are to be reviewed by the experienced obstetrician. So the patient goes in labor. In those cases are to be reviewed by the experienced obstetrician. Epidural can be given, but with epidural we have to remember a few things, that if the dose requirement is high, then think of rupture uterus. Okay, so or scar rupture. So increasing requirement of the analgesia may suggest rupture. Continuous electronic fetal monitoring from onset of labor. So this is one of the indication for continuous electronic fetal heart rate monitoring. So VBAC here, these rupture risk 0.5%, that is 1 in 200, 72 to 75%, previous vaginal delivery, and 85 to 90%. These 4 or 5 things can be asked as a SBA. Okay. Just a moment, someone. Yeah. Now we go ahead. Now what about the augmentation and induction in cases of VBAC? Okay, so can we go ahead with induction or augmentation? What the guideline says, induction and augmentation will increase the risk of rupture by 2 to 3 times, while cesarean section risk is increased by 1.5 times. Okay, 1.5 times there is a higher risk of cesarean section, and 3 times higher risk of uterine rupture if you induce the cases of previous LSCS. Okay. Then senior obstetrician must discuss the decision of induction, method of induction, oxytocin use, monitoring intervals, and criteria to stop VBAC. Okay, so if the patient wants induction for some other the reason, we have another next topic that we will come to know what are the indications for induction. But by any chance the induction is required, then we have to discuss these 3 things: 2 to 3 times higher risk of rupture, and 1.5 or 1.5 times higher risk of cesarean section. Okay, then what the methods can be preferred? Preferred methods will be amniotomy or Foley's. These will have a lower rupture risk than the prostaglandin. Okay, so there may be scenario where the patient is insisting for induction, or there is a need for induction for some reason, and patient doesn't want cesarean section. Okay, so they may ask you the method of induction. So method of induction will be, preferred method will be mechanical methods. Okay, amniotomy and Foley's. Then coming to the elective repeat cesarean section. What is the timing? Timing is always at 39 weeks. Give antibiotics before skin incision. Provide thromboprophylaxis as per RCOG guidance, and placenta previa with prior cesarean section. We need to look into these cases, early recognition, multidisciplinary care, and informed consent is essential if you have a placenta previa along with prior cesarean section. Okay, because you have to rule out the placenta accreta spectrum in these particular cases. So special circumstances, caution with VBAC. Which patients you will be very cautious? Patients with post dates, twins, macrosomia, stillbirth, and maternal age more than 40. Okay, so maternal age more than 40 actually has got a less success rate, and even macrosomia, twins, these cases are high risk for the rupture also. If there is a preterm VBAC, it has got a similar success rate as comparable to the term VBAC, and also it has got a lower rupture risk also. Okay. Now, what we have seen up till now was just an executive summary. Now we'll go into the details of the same. Okay, so here, if you remember, if you see here in this slide, so they have mentioned about the Caesarian section rate in the United Kingdom. So overall, if you see, they have mentioned 25.5% Caesarian section rate in the England, and that is around 15% of emergency and 10 to 11% of elective. So that constitutes the total Caesarian section rate in the England, and it is almost same Wales and Scotland, etc., etc. Okay. Now, what is the consensus among? There are various guidelines in cases of these Caesarian sections having subsequent pregnancy. So NICE, RCOG, ACOG, what does they say? Planned VBAC is safe for most women with a single previous lower segment Caesarian section. So the consensus on all from these guidelines is that planned VBAC is safe for most women with a single previous lower segment Caesarean section. So it is supported by health economic, because you know, the cost will be cost effectiveness will be there and all these things. Now let's go into the antenatal care schedule for these patients. Okay, so always use the checklist for VBAC as well as ERCS. Okay, and document the counseling also. Whatever the decision is made, that should be documented. Follow NICE antenatal guidelines with specific reviews as needed. Counseling usually after mid-trimester scan by maternity team, and you have to involve senior obstetrician if there is a contraindication to the VBAC, if there is an uncertainty about the mode of delivery, if the patient is requesting for the elective repeat Caesarean section, or if the induction is required mainly after 41 weeks of gestation. Okay, suppose the patient has opted for VBAC but does not deliver up to 41 weeks of gestation, then we may require induction, and all those things what we have discussed in the last slide, that needs counseling. Okay, then other pregnancy complications like the patient has got preeclampsia, breech, FGR, macrosomia, etc., and the final decision whatever is made on the birth is generally by 36 weeks. So from the mid-trimester scan only the discussion will start, then it will continue throughout the antenatal period. Everything will be documented, and the final decision on the mode of the birth by 36 weeks will be discussed, and the senior obstetricians will be involved in certain cases whenever there is a contraindication to VBAC, where there is uncertainty about the mode of delivery, if the patient is requesting ERCS, or if the induction is required, or there is a obstetrical complications. Okay, always give patient information leaflet. Actually, this is for part 3. So whenever the counseling comes, then after that next step is a patient information leaflet mentioning the success rate, risk, and options. Okay, so these are the things which are there. Then which are the patients who are suitable for planned VBAC? Okay, so this we have discussed in the summary. Those cases are singleton, cephalic, more than 37 weeks, single previous lower Caesarean sections, with or without prior vaginal delivery. Okay, evidence supports VBAC as a safe and appropriate for majority of the patients. Always review previous Caesarean section record and look for current pregnancy complication to exclude the contraindications. This is the most important. You have to review the previous records and see what exactly this pregnancy is, including the BMI of the patient, including the whether she is post-dated, whether she has got any obstetrical complication, etc., etc. Because guidelines says single, cephalic, more than 37 weeks, and previous single lower segment. So these are most appropriate patients. Okay, so what are the contraindications? We have seen 3 contraindications. Previous uterine rupture, it has got a rupture risk of more than 5%. Remember, the rupture risk is more than 5%. Okay, 5% or more in cases of if there is a previous uterine rupture. In classical Caesarean section scar and major placenta previa, these are the 3 contraindications for VBAC. Rest of the contraindications are relative. Like if it is a complicated scar like an inverted T, J-shaped, low vertical or extensive extension, in that particular case what is required is a senior's review, and then they will be deciding the mode of delivery. If it is a previous uterine surgery, myomectomy with cavity breach, histoscopic septal resection, etc., the rare rupture, but the risk is uncertain. Okay, in these cases the risk is uncertain, so the senior's review is required. Okay, then placenta related risk after Caesarian section. Now she has undergone previous Caesarian section. What is the risk in this particular pregnancy? Again, here is a SBA. Okay, placenta previa risk increases with the number of Caesarian section. There is a 1% risk of placenta previa after one Caesarian section, 1.7% after two Caesarian section, and 3 plus Caesarian section, it is 2.8. You can remember 1%, 2%, 3% approximately for placenta previa. Okay, so the risk of placenta previa after one Caesarian section 1%, after two Caesarian section 1.7, after three Caesarian 2.8. Okay, again SBA here. Placenta accreta risk is high with previa plus prior Caesarian section. Now we are talking about placenta accreta risk. So the patient has got placenta previa with prior Caesarian section. The risk of placenta previa, again, it has got association with previous Caesarian section. It is around 11 to 14% with one Caesarian section, 23 to 40% with two Caesarian section, and up to 67% with 5 or more Caesarian section. Okay, so these are the risks. This also we have seen in our last lecture, which we have taken on the placenta accreta spectrum. Okay, so placenta previa and placenta accreta spectrum that we have already covered. Okay, now what does the guideline says about VBAC after two Caesarean section? Okay, so VBAC can be offered after senior obstetricians counseling in cases of previous two Caesarean section, but there is an increased risk of uterine rupture and maternal morbidity is more. Success rate is around 62 to 75%, which is almost similar to single Caesarean section if prior vaginal birth is present. Okay, the risk of uterine rupture here is 1.36%. So what we have seen is a 0.5% with a single Caesarean section, but the risk of uterine rupture is 1.36% after two Caesarean section. Morbidity is increased. The chances of hysterectomy transfusion are also increased. Then labor will be conducted only in centers with immediate surgical back. Women with planning multiple future pregnancies, the VBAC is best because it will reduce the long-term risk of placenta previa, placenta accreta, and hysterectomy compared with the elective repeat Caesarean section. Okay, so these actually the patients who are planning multiple future pregnancy, VBAC is best. Okay, then risk factors for uterine rupture. Now just concentrate on these particular factors, what they have mentioned about the uterine rupture. So possible risks are the short interpregnancy interval less than 12 months. Okay, so if there is a short interpregnancy interval less than 12 months, or the post-date patient is there, maternal age is more than 40, obesity, low Bishop score, macrosomia, and thin lower uterine segment. Okay, so these are the patients or the possible risks for the uterine rupture. Short interpregnancy interval, post-dates, maternal age more than 40, obesity, low Bishops, macrosomia, thin lower uterine segment. Now short interpregnancy interval also has got a increased preterm birth. Okay, then lower uterine segment thickness. Okay, if there is it is less than 2 millimeter, there is a high risk of rupture. If it is 3 or 4 millimeter, in that case it is protective. However, there is no universal cutoff. Okay, so as such there is no universal cutoff, but what has been observed, less than 2 millimeter there is a higher risk of rupture. More than 3 or 4 millimeter, generally it is protective. So these factors, the presence of these factors do not contraindicate VBAC, but should guide counseling and induction augmentation decisions. Okay, so even if your scenario mentions this, it is always a joint or the shared decision making. Okay, so this is not a contraindication VBAC, but we have to include this into the counseling and induction augmentation decision. Okay, now what the antenatal counseling? We will do the antenatal counseling as per the checklist and document all the counseling and final decision before the delivery. Plan for labor. If the patient goes in labor, then what will be the plan that needs to be discussed? use VBAC checklist and patient information leaflets to ensure informed consent, tailored discussion with respect to medical history, chance of VBAC success, and future reproductive plans. And always these particular things they are going to ask in the examination, that is, what are the risks and benefits of VBAC and elective repeat cesarean section at or after 39 weeks of gestation. So in general, if the VBAC is successful, it has got the lowest complication, and the risk will be highest if the VBAC is failed and requires cesarean section. Okay, so these particular figures, so this particular slide, you can take the photograph, and most of the numericals are here, SBs are here. Now, what are the risks in VBAC? Okay, rupture risk we have mentioned 0.5%, that is 1 in 200 with a singleton, single previous cesarean section. What about previous 2 cesarean section? How much is the risk with what we have discussed in the last slide? Anyone?
1.36.
Correct.
1.36.
Okay, 1.36 with previous 2 cesarean section. Okay, so if the patient goes in spontaneous labor, the risk of rupture is 0.4%. Okay, so this is overall risk which they have mentioned. The spontaneous labor is 0.4 to 0.5% they can give. Then if the labor is induced, it is almost 3 times high, that is 0.5 to 1.4%. Okay, if the labor is induced, the risk of rupture is 0.5 to 1.4. If it is augmented, 0.9 to 1.9. So it is 2 to 4 times higher of this. Okay, 2 to 4 times of higher. See, here it is 3 times higher of this. So always remember these particular figures from this point of view. So this lecture and next lecture I'll be telling you how to remember. If you remember this, just remember how they are correlated to each other. Okay, then perinatal death risk is in VBAC is extremely low. It is similar to other first-time mothers. And unsuccessful VBAC will increase the risk of rupture, hysterectomy, transfusion, and infection chances are high. Hysterectomy is required in 14 to 33% of the ruptured cases. So if you have a rupture, almost 1 in 3 to 1 in 6 patients will require hysterectomy. Okay. Now, what are the problems with elective repeat cesarean section? Okay, in elective repeat cesarean section, the perinatal death risk is less, but there is an increased neonatal respiratory morbidity if you conduct this before 39 weeks of gestation, but that can be covered with the use of antenatal steroids. Okay, now long term, there is an increased placenta risk with ERCS, placenta previa, accreta, adhesions, surgical difficulty in future pregnancy. So these are the risks. Now, what about the blood transfusion? With VBAC, there is a slightly increased risk of blood transfusion, around 2% versus 1% in elective repeat cesarean section. So VBAC has got a higher risk of blood transfusion. Okay, hysterectomy risk overall it is not increased, but if the rupture occurs during the VBAC, then definitely the risk of hysterectomy is increased. Okay. Now this particular slide also has got many figures, but not all figures will be asked, but certain important figures you should know. Now coming to the adverse outcomes. Okay, what are the adverse outcomes during VBAC? Okay, chance of antepartum stillbirth, extra 10 every per 10,000 risk after 39 weeks while awaiting the labor. So it comes to around 1 in 1,000. But when there is a stillbirth or perinatal risk, they always calculate per 10,000. So it will be 10 per 10,000. If the patient, if the patient does not undergo spontaneous labor by 39 weeks of gestation, we are awaiting for the spontaneous onset, and the risk of stillbirth will be increased to the extent of 10 per 10,000. Okay, is it clear what exactly they want to say? The risk of stillbirth, if you wait more than 39 weeks of gestation, because this patient is posted for VBAC, so we are going to wait. Okay, the risk of stillbirth will be 10 per 10. Delivery related perinatal death is less with the VBAC, around 4 per 10,000, but it is less with the ERCS, it is less than 1 per 10,000. Okay, so this 4 you can remember with VBAC. Okay, then 1/3 of VBAC deaths linked to the uterine rupture. Risk of death from rupture is around 2 to 16%. HI is around 8 per 10,000 in VBAC. Okay, and 60% cases are due to the rupture, and composite adverse outcomes, that is more these outcomes happening together, the chance is 3 times higher with VBAC as compared to the elective repeat Caesarean section, but the absolute risk is small. Okay, so out of which what we can remember is a stillbirth risk is around 10 per 10,000 after 39 weeks of gestation. Then perinatal death is around 4 per 10,000, and HIE risk is around 8 per 10,000. Remember, this is 10, 4, 10, and 8. These are related to the VBAC. So antepartum stillbirth 10, perinatal death 4, and HIE 10 with respect to VBAC. Okay, all are even figures 4, 10, 4, 8, and 10. HIE is 10. Okay, so now coming to the elective repeat Caesarean section, maternal mortality is slightly increased versus VBAC. Now, vaginal delivery we know is safer. So even if it is VBAC, the maternal mortality will be less, and operative with Caesarean section, the mortality will be increased. So it is 13 in elective repeat Caesarean section, while it is 4 per 1 lakh. So mortality is always per 1 lakh. Okay. So in VBAC, mortality is 4 per 1 lakh, while in Caesarean section it is 13 per 1 lakh. So this figure is important. They have asked these figures in past papers. Okay. Neonatal respiratory morbidity is higher in elective repeat Caesarean section, especially if you carry out before 39 weeks of gestation. So TTN, transient tachypnea of newborn, 4 to 5% in ERCS, while 2 to 3% in VBAC. RDS is 0.5%, while in VBAC it is 0.05%. Now this risk is as per the gestation at 37 weeks it is 11.4, this TTN risk. Then 38 weeks it is 6.2%, and 39 weeks it is around 1.5%. Okay, so future pregnancy risk will be increased placenta previa and accreta risk, adhesions, and surgical complications. So these are the risk with the elective repeat Caesarean section, where you should remember the mortality. This mortality they are going to ask. Okay, the TTN is high with Caesarean section, 4 to 5%. RDS is also high, 0.5% in ERCs, and they are very less in cases of VBAC. Okay. Now, summary, same thing what we have discussed. Overall success rate is 70 to 75% that we have seen. Same slide is repeated. Okay. What are the best predictors of the VBAC? Previous vaginal birth, 85 to 90%. Okay. Lower success rate is with induction, BMI more than 30, no prior vaginal birth, labor dystocia, advanced age, and high birth weight. This has got a lower success rate. Best predictor, previous vaginal delivery, and 85 to 90%. Other favorable factors, same, like opposite to this. Maternal age is less than 40, BMI is less than 30. If it is a spontaneous onset, vertex presentation, station is low, bishop is good, malpresentation as per as prior Caesarean section indication. So if she has got a previous indication for malpresentation Caesarean section, then thus it is favorable in this particular case for VBAC. Okay. Ethnicity, higher success rate in white compared to the black women. Then there are prediction tools, but these are not routinely used. They have got a scoring based on the bishop's age, indication for Caesarean section, BMI. These are not asked. Okay, so I'll not go into the details. Okay, now coming to the intrapartum management. So planned VBAC only in equipped delivery suites with 24/7 staff. Monitoring is must, and immediate C-section facilities and neonatal resuscitation facilities should be available. Unplanned labor after Caesarean section, the decision should be taken by the senior obstetrician. Epidural is permitted, but if you are getting or noting that there is a high need of analgesia, think of whether it is a case of uterine rupture. Okay, then VBAC, intrapartum monitoring and analgesia, okay, is must. Monitoring, continuous electronic fetal monitoring is one of the indication is a VBAC. Okay, will give continuous one-to-one support, IV access, blood test, etc., etc. Cervical assessment, normal labor progress every 4 hours. Again, epidural may increase the risk of second stage delay and instrumental delivery. Earlier catheter placement is useful. It will provide labor analgesia as well as operative anesthesia also. But there is a conflicting evidence on VBAC success rates, and frequent top-ups may signal uterine rupture. Okay, this also we have seen. Okay. So always look for CTG in these cases. Okay, CTG abnormality is another question. The next question I think is here. Okay, on this slide. So now coming to the uterine rupture, how to recognize and risk. Okay, so signs will be abnormal CTG present in around 66 to 76% of cases. So they may ask you this, the sign of uterine rupture. So abnormal CTG, 66 to 76%. See, other will be severe abdominal pain, especially persisting between the contractions, scar tenderness, vaginal bleeding, hematuria, cessation of contractions, maternal tachycardia, shock, loss of station, change in abdominal counter, absent FHR at usual site. Okay, so they may give you this put together, but the answer will be abnormal CTG around 66 to 76% of cases. Now, what is the risk of rupture in singleton? What we have seen, 0.5% during planned VBAC. Okay, if the uterus is unscarred, in that particular case, 2 per 10,000. Okay, then if it is a case of elective repeat cesarean section, it is 0.02%. 90% rupture occurs during labor around at 4 to 5 centimeter. Okay, 90% of the ruptures will be around 4 to 5 centimeter stage. So early recognition, laparotomy, neonatal resuscitation, these are the important steps. Ideally, you have to deliver the baby within 18 minutes of the your decision, and the classic triad will be pain, bleeding, FHR abnormalities. Okay, so this triad is seen, but only in less than 10% of cases. This is what actually they say, that less than 10% will have this particular triad. Now coming to the decision of induction and augmentation, certain things during the executive summary we have already seen that there is increased risk of uterine rupture 2 to 3 times, 1.5 times increased risk of Caesarian section. Okay, and higher rupture risk if there is no previous vaginal birth, or if we have used the prostaglandins, or high dose of oxytocin will have a 4 times increased risk of uterine rupture. Okay. Now, what are the methods? Safe will be amniotomy or Foley's catheterization. These are the mechanical methods rather than prostaglandins. Prostaglandin rupture risk is high. So these figures are not asked, so I will not go into the details of this. And the counseling by the senior obstetrician is must. Okay. Then planning and conducting ERCS. What we have seen up till now is a VBAC. Now let's talk about elective repeat Caesarian section. It is timing will be around or after 39 weeks of gestation. Antibiotics is required before skin incision. The antibiotic of choice is a cefuroxamine plus metronidazole. This can also be asked as a SBA. Okay. Avoid co-amoxiclav due to any serious necrotizing enterocolitis can happen. Okay. So thromboprophylaxis as per the RCOG guideline. Then placenta previa and accreta, early recognition, placenta multidisciplinary approach, informed consent, and as per the RCOG we are going to manage. Okay. Now, if you delay the Caesarean section from 38 to 39 weeks, so we have seen they recommend the Caesarean section at around 39 weeks because the respiratory morbidity is less. If you carry out at 38 weeks, the respiratory morbidity is 6%. That will be reduced to 1% just by waiting for 1 week. But slightly increase antepartum stillbirth to this extent, 0.05%. Okay. If ERCS is before 39 weeks, consider maternal corticosteroids. Betamethasone reduces respiratory distress by around 50%. So if you buy for any reason you want to do before 39 weeks, the maternal corticosteroids will be used. Now coming to the special circumstances, what we have seen up till now was a just otherwise low risk case apart from Caesarean section. Now, if you have a case more than 41 weeks of gestation, then what is the role of induction? Induction reduces the perinatal mortality in general, but in women with prior Caesarean section, higher risk of emergency Caesarean section, almost 1.5, and risk of scar rupture is 2 to 3 times. So always senior review at 41 weeks. Consider provisional ERCS versus induction depending upon the cervix and maternal and fetal condition. So it is a senior decision. Okay. Then in case of twin gestation, VBAC success rates are similar to singleton, around 45 to 84%. However, the guideline specifically mentioning or the guideline is suitable for singleton cases. But for twin gestation, they mention the VBAC success rate is similar to singleton. What about fetal macrosomia? That is more than 4 kg. Risk of uterine rupture is increased. Odds ratio is around 2.6. Failed VBAC is around 2.5 odds ratio. Okay. And shoulder dystocia, severe parental tear, these are increased. Success rate is less than 50% with fetal macrosomia. So if you have asked the success rate and expected birth weight is more than 4 kg, the success rate will be less than 40%. So just don't remember one figure of 72 to 75%. Please remember other figures also. Okay. Then antepartum stillbirth, high VBAC success rate around 87%. Rupture risk is around 2.4% if induction or augmentation is required. So if there is antepartum stillbirth, you still can go ahead with the VBAC. The success rate is good. Okay. But the rupture risk is also higher, provided the induction or augmentation is correct. If it is a spontaneous, then success rate is good. Okay. Maternal age more than 40 years, higher risk of stillbirth and failed VBAC. Then consider delivery by 39 to 40 weeks. Okay. Then preterm VBAC has got a similar success rate, around 73%, and risk of rupture is also less in preterm. So preterm VBAC is same success rate. Okay. Now there are certain charts and tables from the guideline, out of which this you can remember VBAC success rate is 72 to 75% and uterine rupture is 0.5%, what we have discussed. Okay. The induction and augmentation will have higher. Okay. Then just wait a moment. I think someone is here. So here, birth choices after Caesarian delivery pathway. Successful VBAC 3 out of 4 or 72 to 75% success rate. Successful VBAC after one previous one vaginal birth, it is 85 to 90%. Successful VBAC is more likely in unsuccessful VBAC is more likely in induced labor, no previous vaginal delivery, BMI greater than 30, previous Caesarian for labor dystocia. If all these factors are present, remember success rate is around 40%. So if you have a multiple factors in the scenario, the BMI is high, then it is an induced labor, then the success rate is 40%. So 1, 2, 3. Okay, here these three figures are important. The risk of uterine rupture is 0.5% in VBAC. In ERCS is less than 0.02%. BT risk is high in VBAC, around 2%. Here it is 1%. Serious complication, maternal mortality we have seen, here it is 4 and here it is 13. So these two figures are also important. Okay. This figure, these three figures. Okay. Then transient respiratory morbidity 2 to 3% in VBAC, while ERCS it is little higher, 4 to 6%. Antepartum stillbirth 10 per 10,000, it is not applicable here. HI is around 8, here it is less than 10, less than 1 per 10,000. Okay. So these are the important points. Then definitions, this actually not from SBA point of view, so I will skip this. This also we have discussed what exactly we have to do mid-trimester scan, then discussion will start from here. Then not only that, we have to look into the placenta, repeat scan at 32 to 34 weeks if it is a low-lying placenta, and always have a discussion with the seniors. So the same thing is mentioned here. Always obstetrician review at 36 weeks of gestation to determine the mode of delivery for women who opted ERCS or undecided on mode of delivery or have complicating obstetric and medical disorders. Okay, so this obstetrician led assessment at 36 weeks of gestation. And after 39 weeks, performing ERCS, then what are the advantages and disadvantages that we have definitely seen. By any chance, if the patient does not go into the labor or the patient has wants to wait further, in that particular, again at 41 weeks, senior obstetrician led assessment is important. who had opted for planned VBAC but have not gone into the spontaneous labor. Risk and benefits of various options are discussed and documented. Options include membrane sweep, prostaglandin, amniotomy, or Foley's catheter induction of labor. Okay, or she can have ERCS, or she can also have expectant management. So all these are the options which are available. Okay, and it is always a shared decision making, but still these are safer. Amniotomy plus Foley's will be safer, but still the patient, if she chooses to wait, then that also her wishes are also to be respected. Okay. So here same success rate, everything is duplicated, so I will not go into that. Okay. Again, here this risk we have discussed. Okay. Yes, here risk of anal sphincter injury in women undergoing VBAC is 5%. Remember, risk of anal sphincter injury in VBAC is 5%. Okay, birth weight is the strongest predictor for this, and the rate of instrumental delivery is also increased up to 39% in VBAC. Okay, so sphincter injury 5%, birth weight strongest predictor, and instrumental delivery rate 39%. All 4 and 13 we remember. Now this everyone should, no one should forget these two figures, 4 and 13 for maternal mortality. VBAC is less, Caesarian section is high. Again, these figures we have gone into details. HIE is 8, okay, and 4 is for perinatal death in VBAC. Okay, so that finishes the topic along with various numerical questions from VBAC. Thank you very much. Okay. So our next topic is NICE guideline on inducing the labor. This guideline is published on 4th November 2021. Okay. So what are the early pregnancy discussion? We have to discuss in early pregnancy about the expectant management, induction, and planned cesarean section. So discussion becomes quite early in the antenatal period, and this discussion should be recorded, and it should be what is the preference of the patient, that should be noted. And even this decision making continues throughout the antenatal period, and we have to note these decisions. Okay, and later antenatal visits we have to reconfirm whatever the preferences which were given, that should be reviewed. Okay, and explain the nature of induction. So what kind of and this induction is a medical intervention, and it affects the birth options and experience. So this is actually a medical intervention which will be carried out. Okay, so we have to explain to the patient that it will involve the per-vaginal examination, what will be the choice of the birthplace, because it is an induction, it is a medical intervention. She will have a limited choice of birth options, such as home delivery not possible, midwife-led unit delivery is also not possible, so consultant-led unit will be available for her. Okay, and what are the possible restrictions on water birth we have to mention. Then higher chance of assisted vaginal birth, such as forceps, vacuum, and increased risk of obstetric anal sphincter injury. Risk of hyperstimulation with drug is high. Labor may be more painful than spontaneous labor, and hospital stay may be longer. So these are the things which we need to discuss. Then discussion with women when you have offered the induction. What is the reason for the induction? When, where, how it will be done? Support and pain relief arrangements we need to discuss. Alternatives if induction is declined or stopped, that also we need to discuss. Risk and benefits of induction in their situation, that will be discussed. Okay, and before offering the induction we have to discuss and give them the time for the patient, the partner, to decide on this, and always provide the information sources or the information leaflets, encourage questions. So these are the things actually important from part 3 point of view during the communication from with the role play. Okay, now coming to the very specific things in this particular guideline. Okay, so what they say, various specific circumstances such as pregnancy more than 41 weeks, then PPROM, that is preterm premature rupture of membranes, pre-labor rupture of membrane, that is rupture of membrane after 37 weeks, then previous cesarean birth, maternal request, breech position, FGR, suspected fetal macrosomia without diabetes. Okay, for diabetes we have a guideline, NICE guideline, so that will be followed. But if it is only plain suspected macrosomia without diabetes, that will be covered here. And IUFD and stillbirth, and here IUFD stillbirth rates are also important because these are the SBS. Okay, So what is the role of induction in various these particular things that we are going to discuss? I think we should discuss this stillbirth as early as possible. Yes, this slide tells about, because these are the numerical questions which are asked. So higher stillbirth rate in black babies, it is around 74 per 10,000. I have already mentioned, when you have a stillbirth rate, denominator will be 10,000. Okay, when you have mortality, it will be per 1 lakh. Okay, and rest of the adverse events, most of the time it will be in percentages. Okay, so you get confused, you just remember this figure but forget the denominator in the examination. So higher stillbirth rate in black babies 74 per 1000, white has got 34 per 10,000, and Asian will have 53. So remember, this is 50, 75, and this is 35. Okay, white has got 35 per 10,000 because they ask specifically with respect to ethnicity specifically. So all these three figures we have to remember. Okay, then the patients who are deprived of the services, most deprived areas will have around 47 per 10,000. List will have a around 26. So here again it is a double of this. So least deprived area will have 20, maybe you can remember 25 and 50. Okay, and these are the women from the most deprived area which requires closer monitoring. Now fetal monitoring, if she is awaiting even after 42 weeks, then she has to undergo 2 times CTG in a week and ultrasound amniotic fluid. However, it is optional because it has got a limitation, because it will give you only snapshot. It cannot reliably predict or prevent adverse outcome. So this is to be offered, but we have to tell that it has got a limitation because it is a snapshot investigation which will tell the well-being currently, but it cannot reliably tell or predict about the future outcomes. Okay, again here it looks very complicated, but they are talking about the spontaneous labor at a specific gestational age. Now, at how many patients will go in spontaneous labor at what weeks of gestation? This is what is shown in this particular guideline. Here, just concentrate on this. We know that term is between 37 to 42. So this is the term. Sorry, 30 from here to here is a term. Okay, before this is a preterm and this is a postterm. Okay, now here all preterm total is 8%. This is universally constant 8%. Okay, so 8% are here and 1% is here. Okay, postterm are 0.9%, around 1%, and 8% is here. So this 8% is also divided into 2.5 and 5. Okay, 2.5 and 5.5 you can remember. So 2.5 and 5.5. So less than 31 weeks is 2.5, 32 to 36.6 is 5.5. Okay, so this becomes 8%, this becomes 1%. Okay, so these particular figures you can remember in this particular way. Now we know that expected date of delivery correspond to the 40 weeks. So here will be the expected date of delivery of these patients. So in that particular week, prior to the expected date of delivery, in that week 25% patients will deliver. Okay, so just prior to the expected date of delivery, in that week 25% will deliver. Half of them will deliver 1 week prior. So between 38 to 39 weeks, 12.5 will deliver, or 12% will deliver. Okay, and half of that will deliver after 37 weeks. Okay, here another after 40 weeks. Okay, expected date of delivery, in the next week you will 32.5% will deliver. Half of that will deliver between 41 to 41.6 weeks of gestation. So you can remember in this particular, generally I remember these two things: a week prior and a week after EDD. 25% and 32% you remember. Then make half of that here, make half of that here, and these two figures are same. Okay, so not very complicated, but they can ask you how many patients remain undelivered after 41 weeks. It is 0.9%. Okay, or what is the preterm rate? Preterm rate is around 8% overall. Okay, Now, induction of labor in specific circumstances. First circumstance is pregnancy more than 41 weeks of gestation. What does the NICE guidelines say? So, spontaneous, most of the women will go in spontaneous labor before 42 weeks of gestation and offer every opportunity for spontaneous labor before 41 weeks of gestation. So, definitely we will wait till 41 weeks of gestation. Okay. So risk beyond 41 weeks, there is increased risk of Caeserian birth, NICU admission, stillbirth, and neonatal death. Induction at 41 weeks. Now, if you carry out the induction at 41 weeks, it will reduce all these risks. Okay, and women should weigh benefits versus impact on birth experience. If the induction is declined, we have just mentioned that she should undergo investigations such as twice weekly CTG and ultrasound. This has also been asked. Okay, what monitoring is advised? So 2 times CTG in a week and ultrasound amniotic fluid check, that we have to do, but it has got a limitation because it's just a snapshot. Okay, however, ongoing review will continue and we need to rediscuss about decision at each review. Okay, she can change the decision at any time. Advised to contact the unit if they change their mind about the induction or concerns about the baby, such as reduced fetal movements. Okay. Then preterm labor rupture of membranes, PROM. Here, remember, before 34 weeks, generally induction is not recommended. Conservative management is there. So do not induce unless there are additional indications such as infection, fetal compromise, etc. So in these cases, only before 34 weeks, the labor will be induced. Otherwise, till 37 weeks, the expectant management is followed. Now, between 34 and 36.6 weeks, there are two things. Patients who are GBS positive, immediate induction and cesarean section is carried out. Between 34 and 36.6, if there is no GBS infection, you can discuss both options, either expectant versus induction. Both options can be, and it is a shared decision making. Okay, what are the risks to the mother with conservative management? Sepsis, then Caesarean, and risk to the baby will be sepsis, prematurity, NICU availability, etc. etc. Okay, so these are the things which you should remember. Generally, if you have a scenario, prefer this conservative management before 34 weeks of gestation, provided there are no these factors. Okay, now after 37 weeks, there is a PROM, but after 37 weeks, here expectant management is only for 24 hours because we will wait for the spontaneous onset to happen. And immediate induction, how many percentage of patient will go in spontaneous labor after 37 weeks if there is a PROM? Anyone tell me? How many percent patient will go in spontaneous labor after 37 weeks? Yes, around 60% patient will go in labor in first 24 hours. Okay, if expectant management is chosen, induce if labor is not started after 24 hours. So conservative management up to 24 hours. After that, we can induce. If woman chooses to wait more than 24 hours, respect decision and discuss ongoing options. If GBS positive at any time in pregnancy, offer immediate induction or cesarean section. Okay. For maternal request, consider induction only after discussing risk and benefits and respecting women's preference. So we have seen what the NICE guidelines says for 41 weeks of gestation, for PROM before 37 weeks, after 37 weeks, for maternal request, and next indication is a fetal growth retardation. If fetal growth retardation with confirmed fetal compromise, do not induced. Okay, if FGR is with fetal confirmed fetal compromise, offer instead of that, you will go ahead with a Caesarean section. Okay, FGR prefer Caesarean section provided there is a fetal compromise. Okay, then previous Caesarean birth. If she is a case of previous Caesarean birth, we have just seen that it increases the risk of emergency Caesarean section. Risk of rupture is also increased, and preferred methods will be mechanical methods. Okay, if there is a history of precipitate labor, then routine induction is not justified. Okay, to avoid the unattended birth. Suspected fetal macrosomia without diabetes. Okay, options will be expectant management, induction, or Caesarean section. Okay, what does the evidence say? Induction will reduce the shoulder dystocia risk, but induction will increase the 3rd and 4th degree perineal tears or obstetric anal sphincter injury. There is no difference in perinatal death, brachial plexus injury, or emergency Caesarean section. Okay, and consider women's preference and experience. Breech position, again, for breech it is not recommended. Induction is not recommended for the breech, only in certain cases. If expedited birth is needed and ECV is unsuccessful or declined or contraindicated, in those patients the breech, the labor can be induced. Or if the woman declines Caesarean section, then we may consider induction. Otherwise, generally it is not recommended. Okay. In cases of suspected fetal macrosomia, we have just seen what exactly is done. Okay. In cases of IUFD, the most important is the emotional support and the specialist support. Okay. These two things are very, very important. If the patient is physically well, membranes are intact, there is no infection or bleeding, discuss all options, that is expectant management, induction versus Caesarean section. Okay. And respect her choice. If membranes are ruptured or there is infection or bleeding, immediate induction or Caesarean section. If induced, monitor contractions, provide 1:1 midwifery care. Now for induction in case of IUFD, there are two things: whether the uterus is scarred uterus or unscarred uterus or scarred uterus. If it is an unscarred uterus, the option of choice will be mifepristone 200 milligram followed by dinoprostone vaginal or misoprostol. Okay, oral as well as vaginal. Other option is a mechanical. So unscarred uterus, we can go ahead with the mifepristone followed by dinoprostone vaginal or misoprostol oral or vaginal. If it is a case of previous Caesarean section, there is increased risk of uterine rupture. The mechanical methods will be preferred and avoid prostaglandins. Okay. Now, what does the guidelines say? NICE guidelines say about the induction of methods of induction of labor. So membrane sweeping, whether it is a method of induction or not, because here actually it is not a pharmacological intervention, but still it is included in the guideline under these methods of induction. So membrane sweeping, when it is done around or after 39 weeks of gestation with the verbal consent. Okay. So what is the consent required for membrane sweeping? It is a verbal consent, remember. Okay. So they ask you various situation and what type of consent is required. So if they ask you about membrane sweeping, only the verbal consent. Okay. Then offer repeat sweeps if the labor does not start. Then what are the pharmacological and mechanical methods? Again, it will depend upon the Bishop score. If the Bishop score is 6 or less, then the dinoprostone, either in form of tablet, gel, or control release, we can give, or low dose oral misoprostol, that is 25 microgram, or then what we have a mechanical method, that is balloon or osmotic dilators, if the prostaglandins are not suitable. Okay. In such cases such as previous Caesarean section. If Bishop is good, then amniotomy plus oxytocin infusion can be tried. So if you are given a scenario, check for all these points, what is the Bishops they have given and all, and select accordingly. Okay. So if good Bishops, amniotomy with oxytocin can also be used. And if woman may decline oxytocin or delay it, that will lead to the slow labor, and it may increase the risk of infection also. Okay. Now, what are the risk and monitoring during induction of labor? If you have used dinoprostone and misoprostol, there is a risk of hyperstimulation. It needs regular monitoring of the uterine activity plus fetal condition. If hyperstimulation is there, first thing what we are going to do, stop the drug, remove the pessary or gel if possible. And dinoprostone pessary is easier to remove than gel or tablet. This sentence is very important. Pessary is easier to remove than the gel or tablet, because they give you the scenario, they ask you what method of induction, they will give the Bishop score and all, they'll give you dinoprostone gel, pessary also, okay, and tablet also. Here the dinoprostone pessary you can select because it is easier to remove, because hyperstimulation is the most important risk in the induction with dinoprostone, and that can be removed. Pessary can be easily removed than the gel or tablet. Then you have misoprostol hyperstimulation, harder to reverse, and mechanical method, generally there is a less risk of hyperstimulation. Okay. So what we assess before the induction, we know all in our routine practice, so I will not go into the details. So these are the points which we need to assess before induction: that per abdominal, per vaginal examination, ultrasound to confirm live presentation, Bishop score, confirm good CTG and all. So these are the things before induction we are going to. Now, when you are asked about the induction of labor, please do not select these options at all. Okay. So these are the oral dinaplaston is not, IV dinaplaston is not recommended. So these options are not recommended. So never select any of these. Okay, non-pharmacological measures like castor oil, enemas, etc., etc. Okay, say for example, previous Caesarean section, go for mechanical ones. Okay, you have got a Foley's catheter or dilators. So these are the options which are to be selected. Okay. Then coming to the monitoring during induction of labor, after contraction start with prostaglandins, assess for fetal well-being and contractions by CTG. Always continuous CTG monitoring is required. CTG is normal, review the case. If it is a low risk, then intermittent auscultation, you may go ahead. If there is abnormal FHR or hyperstimulation, continue or restart continuous CTG and stop further doses. Okay. So if she is otherwise low risk case, you may shift to intermittent auscultation also. Okay. Remove vaginal pessary or device if possible. Okay, if there is a abnormal CTG, stop further doses, remove vaginal pessary or device if possible. Okay, reassess women's well-being plus Bishop score at intervals, method given. Okay. And for pain relief, inform women that induced labor is usually more painful than spontaneous, and these are the options which can be given. That is simple analgesia, water bath, and epidural analgesia. Generally, the pain relief in labor or the labor analgesia is a separate topic that we can have a separate lecture for this, because one or two questions are generally asked on the labor analgesia also. Now, is there any role of outpatient induction? What does the guidelines say about it? Okay, this can also be considered if there are no medical or obstetric complications and a woman wishes to go home. Okay, again, it is a shared decision making. There should be no medical or obstetric complication. And what is the method which is used for outpatient? Vaginal dinoproston or mechanical methods can be used. Okay, we'll do the full maternal fetal assessment, ensure safety and support systems in place, agree review plan, and advise women to contact if the contractions will begin or there is a rupture of the membranes or bleeding or reduced or altered fetal movements or excessive pain, hyperstimulation, etc. She will report the unit. Okay. Now, how to manage about these complications? So what complications can happen during the induction of labor? There can be uterine hyperstimulation. Always do the fetal assessment and stop the induction drugs or remove pessary or device and consider tocolysis. Now, unsuccessful induction. You have induced, but the patient has not gone in active labor. What are the options which are available? Discuss and support woman, reassess maternal and fetal condition with CTG, and agree whether just to give the rest and reassess again, or just wait expectant management, or whether to induce the labor immediately, or whether to go ahead with the cesarean birth. So these are the options which we need to discuss with the patient. Next complications are cord prolapse and how to prevent it. So before induction, check the fetal head level and stability. On vaginal examination, you can check for cord presentation, but always avoid dislodging the head. If membranes have ruptured and presenting part is not engaged, you may put the patient on continuous CTG, discuss risk and benefits, consider Caesarean section. Okay, if the patient is stable, CTG is normal, then intermittent auscultation can be offered. Okay, but most important, do not lift the fetal head. Then placenta previa and APH. Ensure low-lying placenta on scan before you sweep or induction. Okay, before sweeping, you have to look for this. Then you can prevent this APH. And then uterine rupture, if suspected, the management is a category 1 Caesarean section. Okay, so there are 4 categories which we'll see later on in any other lecture. Okay, so these are the certain key terms which they have used in the guidelines, that more than 8 or equal to 8 is the cervix is favorable. These are the actually figures. I don't know why they have included like this: more than or equal to 8 is cervix is favorable, less than 6 or equal to 6 is choice of method is pharmacological method. This is what they have not considered. 7, I don't know, but dinoprostal is a PGE2. Okay, suspected fetal macrosomia. So estimated fetal weight is more than 95th percentile at 36 weeks of gestation. Okay, so and it has got a chance of unsuccessful induction. Okay, so these are the key certain keywords or key terms they have used in the guidelines. So that finishes the guideline on induction of labor also. Here mainly you should know about various gestational ages and the spontaneous and what are the different methods of induction. Okay. Now the last is our SIP, hardly 5 minutes will take. The induction of labor at term in older mothers. Okay. So this is a scientific impact paper number 34. It is published in February 2013. Okay. So this particular table gives you the stillbirth rate and neonatal death. Okay. So at different age group, what is the stillbirth rate? Okay. So between 25 to 29 weeks, 29 age, it is a 4.6. Okay. And it is almost same here, but if you see more than 40, it is almost double, 7.6. Okay. So this particular you can remember here in this particular table. Okay. The next table again shows absolute risk of stillbirth in women of advanced maternal age, what they call it as AMA, advanced maternal age, between 37 and 41 weeks of gestation. So here it is a weeks of gestation and here it is a years. Okay. So less than 35 years, 35 to 39 years, and more than 40 years. Okay. So concentrated because elderly mothers, it is more than 40 years. It is 1 in 1064 at 37 weeks of gestation or before 38 weeks of gestation. Between 39 to 40, it is 1 in 500, and after 41 weeks or 41 weeks of gestation, after 40 years, it is 1 in 400. Okay. So 400, 600, 1000. You can remember this way. Generally, these they may ask you more than 40 years. So what is the background and introduction? The average age of childbirth is rising significantly across Western countries. In the UK, maternities, women aged more than 35 years increased from 8% to 20%. Maternities in women more than 40 years rose from 1.2 to 3.6%. These figures will not be asked. Okay, advanced maternal age is associated with higher risk of placental abruption, placenta previa, malpresentation, low birth weight, preterm and postterm delivery, postpartum hemorrhage. Increased use of ART raises the risk further due to higher chance of multiple pregnancy, and pre-existing conditions like hypertension, diabetes, obesity become more common with these. That is why these patients are at a higher risk. Okay, we will have another lecture on membranes. Okay, so that about the maternal mortality, they have got a separate guideline for and what care should be taken with the patients who are elderly. Okay, they have specifically given certain guidelines. Even after adjusting for comorbidities, remember. So these patients, we have just seen, these patients are at risk of all these things, especially these patients can have a pre-existing comorbidity. But even if you adjust statistically adjust these comorbidities, then also advanced maternal age independently increases the risk of antepartum and intrapartum stillbirth. Neonatal mortality is also increased. And epidemiological evidence, what does the epidemiological evidence says that women who are more than 40 years, their risk of stillbirth at 39 is same as young patients stillbirth risk at 41 weeks. So young patients stillbirth risk at 41 is these people will have at 39 weeks of gestation. Okay. So inducing the labor earlier in older women could be justified. That is why this scientific impact paper says inducing labor earlier in older women could be justified, but must be weighed against the potential increase in the emergency Caesarean sections and the neonatal risk. Okay. Now, what is the risk of stillbirth in older mothers? Unexplained stillbirth rise with both maternal age and gestational age in nulliparas and multiparas. Lower cumulative risk of parental death occurs at 38 weeks. Okay. So at 41 weeks, stillbirth risk below 35 years, it is 0.75 per 1000. After 40 years, it is 2.5 per 1000. Okay. This is actually USA study. Effect remains after adjusting for medical disease, parity, race, and ethnicity. And there are ethnic disparities. Afro-Caribbean women will have 2 times higher stillbirth risk compared to Caucasian and Asian women. Nulliparous women more than 40 years have a higher risk of intrapartum stillbirth due to intrapartum anoxia. That is why these particular women who are more than 40 years of age, induction of labor can be considered at around 39 weeks of gestation. Then what is the etiology of stillbirth in older mothers? Exactly not known, but what they have found, FGR increases with maternal age. Adjusted odds ratio for FGR is around, for 34 5 to 39 years 1.4, and here it is 3.2, so almost double. But again, these figures will not be asked. You just remember FGR is increases with the maternal age. Okay. However, FGR is not more common in stillborn babies of older mothers compared to younger ones. Routine FGR or Doppler for all older mothers is not currently supported evidence. Okay. Coming to the neonatal mortality. Neonatal mortality is higher in mothers less than 25 and more than 40 years. In UK, women more than 40 years are 1.3 times more likely to have a neonatal death than those aged between 25 to 29. This is the safer age group. Okay. Absolute risk of neonatal death as per the table 1, which is given in the SIPs, it is 1 in 345 for this age group, and for more than 40, it is 1 in 263. That is the absolute risk of neonatal death. Okay. Coming to the intrapartum complications in these elderly patients, aging impairs the myometrial function, increases the risk of labor complications. So older mothers will have a higher risk of instrumental delivery, Caesarian section for dystocia, prolonged labor. Risk increases linearly with age and especially in nulliparous women. Adjusted odds ratio per 5 years of age will increase for instrumental delivery 1.49, intrapartum Caesarian section again 1.49, and in nulliparous women more than 35 years, prolonged labor more than 12 hours, and surgical intervention due to dystocia is increased almost by 33%. Okay. Older women are more likely to need oxytocin augmentation and higher doses and longer duration of oxytocin for vaginal delivery success. Okay. So high chance of that they will require augmentation. Okay. Now, will induction of labor at term will improve the outcome? This is what is the question in this paper they have answered. So what is the current practice and perception? Induction at term is widely practiced to reduce the late stillbirth risk in older mothers. What does the survey data say? 37% of obstetricians offer induction at term to women between aged between 40 and 44. 55% will offer to the women aged more than 45 years. Elective Caesarean section rates are rising with age, often due to lower threshold among patients and providers. Again, these figures are not important from the SBA point of view. What are the Caesarean section consideration? NICE recommends shared decision making regarding Caesarean and versus vaginal birth. Planned Caesarean before 39 weeks will have a high risk of neonatal respiratory issues and NICU admission. Emergency Caesareans will carry higher risk than vaginal birth. Vaginal birth after induction remains common in older nulliparous women. Okay. So induction versus expectant management. Induction at or after 41 weeks improves the perinatal outcomes without raising the Caesarean section rates. This is as per the Cochrane review. NICE recommends induction beyond 41 weeks to prevent post-maturity stillbirth. Evidence shows induction from 37 weeks can improve the outcome without increasing the Caesarean sections. So, but what the data says on the older mothers, there is a limited data specifically for older women. So when the UK data is applied, inducing all women who are more than 40 years at 39 weeks instead of 41 weeks, 17 stillbirth will be prevented. So, and what will be NNT, that is number needed to treat, is high, 9,340 inductions. If the induction is carried out at 40 weeks, you will prevent 7 stillbirth, but the number needed to treat will be 4,750. Okay. So what is the final opinion and recommendation from this SIP? Stillbirth risk at 39 to 40 weeks for more than 40 years is 2 per 1,000. For less than 35 years, it is 1 per 1,000. Since women who are more than 40 years at 39 weeks have a similar risk as younger women at 41 weeks, induction may be justified earlier. This we have seen what exactly they want to see, say that for young reproductive age group patients, whatever is the risk at 41 weeks, these women will have at 39 weeks. And that is why the induction is justified. Okay. Stronger case for induction if she is nulliparous, comorbidities are present, Afro-Caribbean ethnicity, unclear impact on surgical delivery and neonatal mortality, specifically in older women. Evidence overall suggests no increase in cesarean section or instrumental deliveries with induction. Okay, so these are the certain messages from this scientific impact paper. Elective cesarean section may still be preferred by some older or nulliparous women, and the risk is to benefit discussion is essential in these cases. Okay, so this is what is the final opinion recommendation we can remember. So that finishes today's last topic of induction in older women. Thank you.